For this session, I have taken the topic of evolution and progress of radiography and imaging technology. This is quite important, particularly for the radiographers and even for the student radiologists. How did the progress of science come out? From candlelight to satellite, Coolidge X-ray tube to multi-detector computerized tomography today, naval sonar to power Doppler sonography, lodestone to MRI, splitting of atom to PET scanning. This is the progress of science pertaining to the radiological sciences. Progress of medicine. At one time, we used to study the whole body in order to make a diagnosis. And then organs, specific organs, cardiac, renal, liver, brain, and systems, neurological systems, cardiovascular systems, genitourinary systems like that, musculoskeletal systems like that. And then today, from tissues, you can make a diagnosis, because the entire disorder reflects upon the tissue. And then from tissue, we have come to diagnose by cells, taking FNAC, few cells. And from cells to molecules, from molecules to genes, and regeneration of organs we have come to. That is the result of scientific advanced research. Progress of radiography and imaging technology. 1896, discovery of X-rays. 1920 to 40, radiographic techniques. 40 to 60, contrast media and procedures, various procedures, angiography, esophageography, GI radiography. From 60 to 80, radionuclides have come, as well as ultrasonography. 80 to 05, cross-sectional equipments, ultrasonography, CT, MRI, PET scan. And 2005 onwards, digital radiography is common now. Every machine should be DICOM compatible. PACS, picture archiving system, hybrid and molecular imaging. This is the progress in the imaging technology. Again, to repeat, development imaging modalities, X-rays, 1895 actually, although he has declared in 1896, but in 1895 he has discovered. Ultrasound, 60 to 70, color Doppler, 80 to 90, ultrasound with contrast, 90 to 2000, CT scan, conventional 80s, spiral CT in 90s, MDCT in 2004, and MRIs also, low field strength, 81 to 1990, high field strength, 1990 to 2000. And today we have got 7 Tesla magnets too. That is the progress. Hybrid imaging, PET CT, PET MRI, and of course interventional radiology. Wilhelm Conrad, Röntgen, were always, all our jobs, our professions, owe a lot of gratitude to Professor Röntgen. Discovery of X-rays, 9th November 1895 to be precise, and Nobel Prize he got in 1901. First radiograph of his wife on 22nd December 1895. Look at the wedding ring also. And then in the beginning, look at the scandals. Look at the use, X-rays. X-ray for furniture polish, X-ray whiskey, X-ray soap, X-ray headache tablets, and whatnot. They experimented with everything, not knowing the hazards of radiation. Now, conventional era, plain X-rays of the skull, plain radiographs of the skull actually. Radiography, fluoroscopy has flourished. Then came the stereoscopy, to take stereoscopy films and measure the depth, where the calcification is, say in the lung or in the skull. Photofluorography, these are the various methods of conventional era. And then the basic principle of X-rays is, as the Röntgen himself has described, differential absorption of the tissues. For example, you take X-ray they had. Why are the bones so dense on the film? Because X-rays are not transmitted. All X-rays are absorbed in the bone, so nothing is transmitted. Whereas air, fat, their transmission is high. That's why they are lucent. This is differential absorption, is the basic principle of X-ray use. Chest fluoroscopy we used to use a lot, even in 50s and 60s. fluoroscopy, because of the scarcity of X-ray films, particularly in India, we used to use a lot of fluoroscopy. Then radiography, fluoroscopy of the chest with a handheld fluoroscopy. Then we realized the radiation dangers of fluoroscopy. Now nobody uses fluoroscopy except for some interventional procedures. Even then we have got intensifying screens. Not that much of radiation is emitted. Innovative positions, for example, lordotic chest. We always say chest film is essential to diagnose any lesion, particularly tuberculosis, which is because it is common. But then the infiltrates can be missed. Actually, one of the students from Oxford has done a research paper a long time ago, and he said, when you are looking for lung pathology, the routine PA of the film shows only 30% of the lungs. The rest of it is obscured by domes of the diaphragm, spine, heart, mediastinal structures, clavicles, etc. So, in order to not to miss any lesion of tuberculosis nature, because they always occur in the apical area, we do a lordotic chest. The clavicles are thrown off so you could identify the early lesions, early infiltrations in the apices. And then all of you know that there is pleural effusion can be missed in a routine film of the chest. Early pleural effusion is massive, of course you can see the opacity and tracking along the lateral wall. But minimal effusion you can identify by taking a decubitus lateral. Dependent portion is down so that whatever little fluid is accumulated in the dependent portion, and you can outline the amount of pleural effusion. And then the abdomen, KUB, includes kidneys, ureters and bladder. For any urinary tract pathology, particularly for calculi, we have to do a preliminary film called KUB film. It is a basic screening method to study the abnormalities of the urinary tract. Not only the stones, gas, masses, stones and bones we can study. Apart from calcifications, foreign bodies, swallowed pin, the size, shape and contour and location of the organs, particularly the kidneys, the spleen, the liver, could be assessed from preliminary KUB. Radiopaque calculi, particularly in the urinary tract, can be identified easily, since 95% of these radiopaque calculi, the calculi of the urinary tract are radiopaque. Only 5% consists of uric acid and the cystine type of stones. Proper patient preparation is necessary to avoid overlying gas shadows. Suppose there is a lot of gas shadow or a fluid-filled intestine, fluid-filled stomach, you may miss a small calcification. Calculi of less than 3 millimeters may be missed on pain films also. Bilateral renal and ureteral calculi and the film on the left. On the right side, renal and prostatic calculi also can be seen. Bladder calculi of various sizes, shapes, you can identify. The one on your right side, lower portion, the arrow shows a oval type of calculus in the uretrovesical junction. Conventional era radiography again flourished in between 1920 and 60. It's a technical era, contrast medium. Iodine is radiopaque, that's why we used iodinated contrast media. Barium is radiopaque, we used to use for study of the gastrointestinal tract. And then came the conventional tomography, sectional, particularly for the lungs, spot and serial films. Again, if you see on this, the fluoroscopy, you may not catch it on radiography by the time it is delayed. So spot and serial film radiography, cine radiography to study the dynamic physiology of the urinary, GI and other tracts, nephrotomography and autotomography, not using the machine but using the movements of the head and neck, for example. By oscillating the mandible, you can study the C1, C2 joint, odontoid process. Conventional tomography in 1920, universal tomography in 1954, you see the calcification in the lung, which ordinarily you can miss by conventional radiography. Compression fractures of the vertebra using tomography to identify, and then contrast media. Air is a natural contrast medium. That's why you are able to study the air bubble in the stomach. Lungs or gastrointestinal gas in the abdomen. By that, by studying the morphology of the normal air containing structures, you can study the abnormal morphology. Barium to use, thick paste or thin type of barium is not absorbed, so it is excreted from the intestines. Iodinated compounds, very popular, even today we use, and contrast in specialized contrast in ultrasound and magnetic resonance imaging. Procedures, what are the usual procedures? Occasionally you can innovate newer procedures, but usual procedures, barium meal of the Purgea tract, barium meal of the small bowel, barium meal of the esophageal motilities, and colon studies for barium enema, IV urography, intravenous bronchography by using non-absorbable contrast medium, cholecystography, myelography, arthrography to study the joints and the ligaments, retrograde urography when I.V.P is contraindicated, cystography, hysterosalpingography to study the uterus and uterine tubes, angiography to study the vessels and cardiac chambers, MR contrast medium, interventional radiology. These are all the various procedures that we are doing. Dandy in 1918, he introduced ventriculography by producing burr holes in the skull, and you could study the various ventricles of the brain, lateral ventricles, third ventricle, etc. A ventriculogram has come in 1930 also. 1934, perineal insufflation of air was performed to study the size and shape of the kidneys and also the adrenals and other retroperitoneal masses. Today it is abandoned. Pelvic pneumography to study the size of the uterus, to study the location of the uterine tubes and the ovaries. Absence of uterus in this particular case, rudimentary ovaries in the other case, with contrast into the uterus, pneumography has been done. Various innovative methods to study the various structures. Some of these are abandoned today, only of historical interest. Barium suspensions in 1910 in GI radiology, demonstration of a lesion is a knot, but is forgotten. Today we don't spend much time with barium meals, etc. Gastric ulcer with Hampton's line, protrusion of the niche outside, and compression techniques with spot films. Double contrast media, even today sometimes we use double contrast, air and barium to study the ulcers both in the stomach and the duodenum. And then endoscopy has come and stolen most of our barium series. Not many departments do barium meal studies or even colonic studies by barium enema. Diverticulitis, sinus tract, the endoscopist only sees the lumen, what is happening outside the lumen, in the wall of the colon or outside the colon, you cannot see. In those cases, we adopt barium studies. Air contrast studies to study the polyp, pedunculated or it is sessile. Of course, the endoscopist has got an advantage, he can take a biopsy. And virtual endoscopy has come today with CT. Oral cholecystography, it is abandoned again, not necessary. Floating gallstones in the erect posture. These are the innovative methods that people have adopted, our ancestors. Bronchography to study the bronchiectasis, either localized or generalized. And then we come to history of I.V.P. To notice that we are forming a pattern from head to foot, head and neck, and then we saw the chest, and then we are coming to the history of I.V.P. Moses Swick in 1928 used sodium salt of 5-iodo-2-pyridine acetic acid, called at the time uroselecton, to perform first intravenous pyelography. In 1929, he presented a paper on uroselecton for I.V.P, intravenous pyelography. In 1954, Evans et al. Introduced nephrotomography. That's the period where I was doing residency in New York. Development of contrast media, 1930, Hippurine, 1950, Diodrast and Eurocon, 56, diatrozoic acid, 62, iothalamic acid, 70, metrizinamide, first non-ionic contrast medium. 2007, several non-ionic compounds have come so that minimal reactions, although it is costly, but minimal Contrast-induced nephropathy is a well-documented phenomenon, especially with large quantities. Even today, occasionally we come across. 1927, cerebral angiography. 50, nuclear medicine. 53, modern angiography. 60, ultrasonography. 1970, CT. 80, MRI. And 2002, we got PET-CT. Hybrid imaging. IV urography, ionic and non-ionic. Look at the nice visualization of the calyces, pelvis, but not the entire ureters, only segments of ureters we could see. That's why we use compression technique in order to see the ureters, proximal ureters. Balloon compression of the ureters produces good visualization because the contrast is retained in the calyces and pelvis. Note the extrarenal pelvis in the left kidney. High quality I.V.P. depends upon equipment, technique, contrast media, the dose that is used, monitoring of films. Each film, 1 minute, 2 films, whatever sequence of events you are taking, each film should be monitored so that whether we should go for the next technique or not. High risk, known allergens, infants are high risk. Severe systemic disorders like multiple myeloma is a contraindication. Renal failures, renal transplantation. Low osmolality contrast should be routine, but for the cost involved, clinical benefit should not actually justify the cost. The principle of primum non nocere, do not hurt the patient, implies safer agents should be used whenever they are available and accessible. Bladder examination, cystography, either direct or indirect. Indirect, by doing I.V.P. late films, you can study the bladder. Note on your right side, extensive neoplasm involving the bladder valve, and then on your left side or in the right side of the film, you see blood clots in the bladder producing multiple filling defects. That is this direct cystography. HYSTEROSALPINGOGRAPhy, even today we do certain times, and congenital abnormalities like uterine didelphys, TB adhesions of the ureters, and synecdoche after curettage. All these can be demonstrated with hysterosalpingography. 1937, David Van Dyke, the normal pneumoencephalography. Look at the air fluid levels. It is taken occiput down. Contrast media, ventriculogram was introduced. Arthrography in contrast, rotator cuff tear. And then myelography in 1939. Sometimes we use gas, oil, and then sometimes a soluble, water-soluble ionic media, non-ionic. Current use, of course, we don't use many places, but then say in a district place, where in a CT or MRI, you have to use contrast myelography in order to make a diagnosis. But in general, they refer the cases to the tertiary care centers. Discography, to study the disc, degeneration or prolapse. All these are abandoned now. Lymphangiography, occasionally even today we see, particularly CT lymphangiography, to study the size, shape and distribution of the lymph nodes. Now we come to the heart. PHS was common to study the heart size, aneurysm of the left ventricle, and then IV angiocardography in 1940. Lots of IV angiocardography we used to do, right ventricular, left ventricular. 1927, EGAS Moniz, Spain, first cerebral angiography has done. Earlier radiologists, surgeons, and other physicians were also involved in innovative techniques, and they were expert X-ray technicians at that time. Coronary angiography, even today we do it. SELDINGER, 1953, he has revolutionized transfemoral percutaneous transfemoral angiographic catheterization. Percutaneous femoral catheter route is the pioneer. Periarteritis nodosa, look at the multiple aneurysms in the aortic angiography with renal arteries well outlined. And also you can see cone view of the right renal artery, fibromuscular dysplasia with beaded appearance of the right renal artery, selective renal angiography. Cross-sectional imaging, ultrasonography, CT, MRI, nuclear scan, PET, hybrid imaging. Ultrasonography today, I said nobody does cholecystography. It's forgotten because it's time consuming, contrast media reactions, X-ray exposure. So ultrasonography is the simplest, easiest. No ionizing radiation. 2.25 to 10 megahertz difference in acoustic impedance. That's how the principle is acoustic impedance. That's how you could see the stone, echogenic, and then the refraction. High spatial resolution, harmonic imaging, endosonography you can do, tissue enhancing contrast, power Doppler. This is the lymph node enlargement in the